Chapter 14 in R&M. I need to stress this is a very important chapter. It's difficult. There is a lot of information to cover. I need you all to read this chapter over and over and review this PowerPoint multiple times. It's very important, and I cannot stress that enough. Okay, again, please know this image of the abdominal aorta bifurcating into the common iliacs. Be able to label this on a test, quiz, board exam, all the above. If you have questions, please let me know. Okay. Capabilities here. The aortoiliac vessels we're going to help determine the presence and absence of a significant stenosis. Aortoiliac meaning abdominal aorta, common iliacs. For the renal artery, we are going to determine if the stenosis is greater than 60% diameter reduction. The kidney, we're going to help determine the presence or absence of nephrosclerotic disease and evaluate and support follow-up for transplants. Mesenteric arteries, which are your SMA, celiac artery, IMA, we're going to help determine the presence or absence of significant stenosis, which may cause mesenteric bowel ischemia. For the liver, we're going to evaluate suspected portal hypertension and evaluate pre- and post-liver transplants. The limitations here, the depth of ultrasound penetration is limited by the size of patient. This makes abdominal imaging very hard. Patients who are heavy, bigger in the abdominal area, it's going to be limited. These arteries are very, very small, and when you add layers of fat, obesity here, it's going to be very difficult. You're going to have to push really, really hard on these patients. Bowel gas is really hard and limits us more than you know. You're going to find out, because when a patient has bowel gas, it casts a complete shadow over your entire image. You cannot see through bowel gas. You can roll the patient, try to push through, turn, all the things. Still very difficult. Sometimes there's nothing you can do about it. That's why we have patients fast for these procedures, to help lessen bowel gas. Previous abdominal surgery, scar tissue, you cannot see through scar tissue. It will cast a terrible shadow. Shortness of breath, rapid respiration may result in inaccurate results. Non-fasting patient may compromise results also. All right, technique. We are going to start supine, laying on the back. You can roll the patient onto the left or right side if they're gassy to try to move that gas around. You're going to want to use, with the exception of a renal transplant, everything else you're going to want to use a 3 to 5 megahertz transducer, which is the phased array. All right, aortoiliac artery technique. Aortoiliac here, I'm talking about abdominal aorta and common iliacs. We're going to scan and measure the arteries listed below in B mode. We're also going to get a peak systolic velocity with pulse wave Doppler. We're going to get, for this test, prox, mid, distal abdominal aorta, and then right and left common iliac arteries. Now, how do we read this? We want to make sure when we measure the abdominal aorta, it needs to measure 3 centimeters or less. Over 3 centimeters of the abdominal aorta is going to be considered an abdominal aortic aneurysm. The majority of the abdominal aortic aneurysms, or AAAs, are atherosclerotic and infrarenal, which means they have plaque in them and they are below the renal arteries. Types of AAAs are fusiform, saccular, false, and dissecting. They may have thrombus in them. Oftentimes they do. Most frequent complication and danger of AAA is rupture. That will kill a patient very quickly, so it is a major emergency. When you're doing this exam, no, our office, our surgeons will want to operate on an abdominal aorta greater than 5 centimeters. So it's very important that you get a really good, accurate measurement of this abdominal aorta, because it's going to depend, what you get will depend on whether or not the patient will go to surgery. Please, if you cannot see something or are having trouble seeing in clinical or when you're a tech, don't guess. Don't guess. Never say you've seen something that you cannot. If you can't clearly see the walls, state that. Another thing is, a lot of times these patients with an AAA will have no symptoms. Okay, here's a picture. Please know these. If I were to give you an image of an abdominal aortic aneurysm, I want you to tell me which kind it is. Here is a fusiform AAA, and you can see thrombus in the top. Here is a saccular AAA. You can see the little sac that's formed off of the AAA, or off of the aorta, I'm sorry. This is a dissecting AAA. So they all appear very different. It should be pretty easy for you to label which one if given the image. Here's another image of a dissecting AAA. Okay, on to renal artery and kidneys. So many patients that are having a renal artery duplex will have hypertension or HTN. Renovascular hypertension is a secondary form of high blood pressure, often found caused by renal artery stenosis. The narrowing of the artery reduces blood flow to the kidney, and in response, the kidney produces the enzyme renin. Very important. Please remember that. The renal artery will narrow, reducing the blood flow to the kidney, and in response, the kidney is going to produce renin. Again, we're going to use a 3 to 5 megahertz phased array transducer to image these arteries in the kidney. It's going to just allow us to image deeper. We're going to get a peak systolic velocity of the aorta just distal to the SMA. We'll locate the renal arteries in transverse. You can use the left renal vein as a good landmark to find the left renal artery. You're going to evaluate the kidney size and morphology bilaterally on both sides. We're going to obtain peak systolic and end diastolic velocities from the following. The renal arteries, you'll do proximal, mid, distal, both sides. Segmental arteries, which are in the pelvis of the kidney, and interlobular arteries, more distal and outward beyond the pelvis, and then upper and lower poles of the kidney. I have a picture coming soon to help this make sense. Okay, this is what a kidney looks like. Their liver is going to be on top for the right side. Your liver will be on the top, and then just below will be your right kidney. Again, on the right side, you have your liver, kidney. This is taken in longitudinal. Here is a transverse view of a kidney. It's going to look like a circle. Again, okay, so this is really important. On the right side, the kidney is going to lay beside the liver. On the patient's left side, the kidney will lay by the spleen. And here is another image of the kidney in transverse. It's going to look like a C or a circle. Okay, and this is a picture to help you understand the arteries within the kidney. So you have the aorta, the descending abdominal aorta. you can see the renal artery is going to branch off of that and go to the kidney. So first, you're going to have the segmental arteries within the kidney. You'll have the segmental artery, and then interlobular artery, and then arcuate artery within the kidney. Now, we are in vascular. We are responsible for imaging the renal arteries and the arteries within the kidney. However, if we do notice an abnormal mass, cyst, fluid around the kidney, we will note that. However, that's not technically our study. That's going to be general. General will evaluate the actual kidney and morphology. We do look at it and note it. That's not technically our job. However, we do need to note those findings. Again, our job as RVTs is going to look at the renal artery and the blood supply to the kidney. Now, another thing I want to note, normal size of the kidney, 10 to 12 inches. Let me double check that. Centimeters. 10 to 12 centimeters, normal size for a kidney. When you measure the kidney, and I'm going to show you how to do this in lab, you're going to get measurements. That's going to be a huge indication. Is this kidney getting adequate blood supply? Does it measure 10 to 12 centimeters in length? If it measures 8 or under, that indicates to me it's probably not getting adequate blood flow. Okay? Very, very important just to take that into consideration. Now, let's also remember that, say, my kidney is going to measure on the normal low side compared to like LeBron James or an NFL player. Okay, so there's that. Take that into consideration as well. But on average, 10 to 12 centimeters in length is a normal length for a kidney. All right. Low resistance arteries. This is a little bit of a review, but I want to throw this in. Low resistant, high resistant. Please know the difference and know which arteries are which. So a low resistant artery in the abdomen, renal, celiac, hepatic, and splenic. Those 4 are going to be low resistance. Here's another image of your renal artery. You can see here it's branching off of the aorta. So right at the aorta, right where it branches off, that's considered proximal renal artery. Then you follow it up towards the kidney halfway. That's going to be mid. Distal will be right before entering the kidney. Here is a picture of the duplicate renal arteries. Again, that's a common variant to see somebody have 2 renal arteries in the renal vein there in the middle. Okay, now let's talk about what we're going to find when we image these renal arteries. After we image, we're going to get what's called and calculate renal to aortic ratio, the RAR. We're going to calculate that by dividing the highest peak systolic velocity of the renal artery by the peak systolic velocity of the aorta. That's why we always start our renal artery exam with a pulse wave Doppler of the prox aorta. And back to this, the highest peak systolic velocity of the renal artery. You take the highest prox, mid, distal, whatever velocity is highest, you use that for your ratio RAR. A normal RAR is going to be less than 3.5. An abnormal RAR is going to be greater than 3.5. That's going to indicate a greater than 60% stenosis or diameter reduction of the renal artery. Again, let me say that again because this is very important. Abnormal RAR is going to be greater than 3.5. that's going to mean there is a greater than 60% diameter reduction of the renal artery. Now, RAR may not be accurate if you have an aortic aneurysm or when the peak systolic velocities of the aorta are less than 40 centimeters per second or greater than 90 centimeters per second. If you have the absence or reduction of end-diastolic flow for a renal artery, that's going to suggest a distal disease, either in the distal renal artery or within the kidney itself. So if you are scanning a renal prox or mid renal artery and you have zero end-diastolic flow, it's gonna, if it presents high resistance, that's abnormal and telling you distally somewhere between where you are and the kidney, there's a problem. A peak systolic velocity of greater than 180 to 200 centimeters per second with post-stenotic turbulence at any point in the renal artery is going to suggest a greater than 60% diameter reduction. Post-stenotic turbulence, and this is when you'll be able to hear it. It sounds like bubbles, and your waveform peak systolic is going to be jagged. Post-stenotic turbulence suggests a significant proximal stenosis. You're going to examine the kidney for morphologic abnormalities like cyst, tumors, things like that. Again, it's not technically in our job to do that. It's generals, but we do need to scan through and check the kidney for any of those abnormalities so the patient could go to general and have that complete exam. Okay, here we go. Normal kidney length, 10 to 12 centimeters. All right, on to resistive index. I've highlighted this because some little birdies who just took the RVT exam told me this was on the RVT board exam, and I had told them it probably wasn't going to be, so please know this is very important. You're going to need to calculate it and know normal and abnormal. So resistive index for the kidney, you take your highest peak systolic velocity from the renal artery minus end diastolic velocity over peak systolic velocity. Normal is going to be less than 0.7. Abnormal is going to be greater than 0.7. Okay, so renal resistive index value, RRIV, is going to use, this is different from RI. This is going to use the peak systolic velocity and end diastolic velocity obtained from the kidney's segmental arteries, so the arteries within the kidney. RRIV is going to help identify patients whose renal function or blood pressure will improve after correction of the renal artery stenosis. So how do you calculate this? It's going to be 1 minus end diastolic velocity over peak systolic velocity. A lower resistance RRIV value of less than 0.75 is associated with improvement in both blood pressure and renal function after correction of renal artery stenosis. RRIV of greater than or equal to 0.75 is a strong predictor of worsening renal function and lack of blood pressure improvement despite correction of renal artery stenosis. This is not as important as far as I'm concerned as RI and RAR. I really want you to focus on and memorize RAR and RI. Okay, proximal high-grade stenosis or occlusion of the renal artery may result in a dampened but still low-resistant waveform. Let's look on page 148, please. Figure 1415. You're going to get what's called a tardus parvis waveform here. And this is when you have a proximal high-grade stenosis or occlusion of the renal artery. You're going to get what's called tardus parvis. And it's just a very low kind of dinky waveform. Okay. We're going to move on to talk about acceleration time, which we abbreviate AT. That's going to be the time interval from the onset of systole to the initial peak reported in milliseconds. A proximal stenosis of greater than or equal to diameter reduction, 60% diameter reduction, is most likely to produce an AT of greater than or equal to 100 millimeters per second. Okay. Acceleration index is going to describe the slope of the Doppler velocity waveform. The change in the velocity between the onset of systole and the systolic peak divided by the AT at greater than or equal to 60% diameter reduction is defined as an AI of less than or equal to 291 centimeters per second squared. Again, I want you to focus on RAR and RI. Please do know tardus parvus. That's also important. And what that means. What does tardus parvus mean if you see that while you're imaging a renal artery? So again, RAR, RI, tardus parvus. Okay, here's some more pictures of the kidney. On the left, we have a right kidney longitudinal. You can see the red is the renal artery, a ureter, and the renal vein coming in. You've got the upper pole on the left, the lower pole on the right. The cortex is the area surrounding the kidney here. On the right, we have the right kidney transverse. You can see how the renal artery would enter here in the renal vein. Upper pole, lower pole. All right, here is a normal renal artery Doppler. You have the aorta, and then branching right off the aorta is going to be the renal artery. This is a very, very difficult image to get. But I do not ever term it proximal aorta or proximal renal artery unless I can actually visualize it coming off the aorta. You can see this is a low resistance waveform. All right, let's move on to mesenteric arteries. These are going to be your celiac artery, SMA, IMA. All right, why do we do this? We're going to be doing it on patients who present with a history of dull, achy, or crampy abdominal pain 15 to 30 minutes after they eat. That's called mesenteric ischemia or mesenteric angina, belly pain 15 to 30 minutes after eating. Mesenteric ischemia may be caused by a stenosis or occlusion of SMA, celiac, or IMA. When we look at the mesenteric arteries, the patient should be fasting. In fact, patients should be fasting for an abdominal aortic exam, a renal exam, and a mesenteric exam. All of those, they should not have eaten in the past, we say 12 hours. So fasting study is performed. Patient given a fatty meal. You can do Ensure or anything with high fat. What you're going to do is repeat the exam after the patient's had the fatty meal, 20 to 30 minutes after. On the pre-parietal exam, a significant amount of blood flow is not required to the mesenteric arteries because nothing's really going on here. Post-parietal, which means after you eat, more blood flow is going to be required to help to the mesenteric arteries to help digest that food. So when the patient is fasting, which means they've not had anything to eat, the SMA is going to be a high resistant waveform. After you eat, normally the SMA becomes low resistant because you're having to have more blood flow go through these mesenteric arteries to help digest the food. After eating, there's digestive work to do, so the SMA becomes low resistant. The mesenteric arteries are going to dilate to provide additional blood flow. Abnormally, post-parietal, after eating, the pattern of blood flow in the SMA and IMA will stay high resistant. That's abnormal. This most likely means a distal obstruction. Very important to know that the celiac and hepatic splenic arteries are not affected post-parenally, which means the celiac, hepatic, and splenic arteries are not affected when the patient eats. SMA is definitely affected. All right, so let's talk about normal, abnormal. In the celiac artery, a normal peak systolic velocity is going to be anywhere from 50 to 160 centimeters per second. A normal end diastolic velocity would be less than or equal to 55 centimeters per second. Abnormal celiac artery peak systolic velocity of greater than or equal to 200 centimeters per second is going to suggest a greater than or equal to 70% diameter reduction. SMA fasting. Normal peak systolic velocity is 110 to 177 centimeters per second. Abnormal peak systolic velocity for a fasting SMA is greater than or equal to 275 centimeters per second. That will indicate a greater than or equal to 70% diameter reduction. Yes, I do need you to memorize these. And yes, when you are in clinical or working RVT, you will have this chart posted for your reference. But unfortunately, for your quizzes, test, and RVT exam, you do have to memorize this. Let's go to page 153, table 14.1. There is a nice chart I want you to look at and please memorize. Here's a beautiful picture of mesenteric arteries. You have your aorta on the left, your celiac artery, which will be the first branch of the abdominal aorta, and then second branch just distally is going to be your SMA. Beautiful picture. Here we go in transverse. You've got your aorta, and then the celiac artery is going to split into the splenic and hepatic artery. Okay, let's talk about some abnormal things we could see here. Celiac band syndrome, also known as median arcuate ligament syndrome, or MALS, M-A-L-S. It's the extrinsic compression of the celiac artery origin by the median arcuate ligament of the diaphragm. It's common in young athletic women. Normally, high velocity signals are improved when you take a deep inhale. High velocity signals are seen with expiration. So this is what happens basically. And I have seen this in quite a few young females. The median arcuate ligament of the diaphragm compresses the celiac artery, specifically when the patient exhales. So what you need to do is image the celiac artery, and you need to have the patient do inhale, take a velocity, and then exhale, take a velocity. And if this is positive, you will see a huge difference in jump in velocity when the patient exhales. Hepatic and splenic arteries should have low resistant Doppler waveforms. They provide arterial inflow to the liver and spleen. There's no stenosis criteria for this. If celiac artery is occluded, you may see a retrograde flow in the hepatic artery, which means flow is going to come blue backwards. Okay, the IMA is so small. It's not in our protocol, and I'm going to be honest. If you see the IMA, there's a problem. It's probably going to mean that the SMA is occluded, and honestly, you may even mistake it as the SMA. It's a very difficult thing. Again, IMA is not in our protocol because it is so small, and if you do see it, something is likely wrong, and that's likely an occlusion of the SMA. Okay, so again, this is just a great picture to show you what a normal waveform of the aorta would look like, what a normal waveform of the celiac artery would look like, which is low resistance, and what a normal waveform of the SMA before eating a fasting SMA, high resistance. Okay, so here is fasting SMA versus non-fasting SMA. You can see on the left, the fasting SMA is high resistance. 15 minutes post a insure or a very fatty meal, you've got a more low resistant waveform there on the SMA. Okay, liver transplant allograft here. Preoperative duplex evaluation for liver transplantation. So pre-op, we're going to document the patency of portal vein with special attention to check for thrombus here. We're going to look at the splenic vein, the SMV, which is superior mesenteric vein, hepatic veins, IVC, and hepatic artery. Check for abnormalities or tumors. Postoperatively duplex evaluation for liver transplant. We're going to document, again, patency of the portal vein, splenic vein, SMV, hepatic veins, IVC, and hepatic artery. Portal vein flow, direction, vessel size. A normal portal vein size should be less than 1.5 centimeters. I actually have never done a liver transplant. I think you will see these. Correct me if I'm wrong. Let me know. But I think the only place we will see these would be UK. Liver transplant again, allograft. Let's see. Post-op complications include rejection, pseudoaneurysm, hepatic infarct, thrombus of the portal vein, IVC, and hepatic artery. Okay, so let's talk about the portal vein. Again, the portal vein, which we have labeled hepatoportal in our protocol, it is not very common either. A lot of people are not going to see these. Not the hardest scan, but again, just people just don't do them a lot. But we need to go over it because if you do, you need to know what's going on. So portal vein is going to be in the liver on patient's right side. So normal portal vein flow is red, indicating flow towards the liver or hepatopedal. Very, very important. Please remember this. Normal portal vein flow is red. Don't invert the portal vein flow. It is normally red, indicating flow toward the liver, which is also called hepatopedal. So I think of pedal to the liver. Flow is going to the liver, hepatopedal. We're going to pedal to the liver. Pedal. If you like, pedal to the liver. Portal system is going to drain blood from the abdominal part of the digestive tract, which is pancreas, spleen, gallbladder, mesentery, and carry it into the portal vein. The portal vein is going to carry blood into the liver, and then the hepatic veins are going to return the blood to the IVC. The hepatic veins are going to be blue. They are going to take blood away from the liver. Hepatofugal. So I remember this like in my head, hepatofugal, fugitive, going away. We're running away. So pedal is going to be toward the liver, fugal away from the liver. Again, portal vein normally is red. Hepatic veins normally blue. Portal vein is going to be formed by the SMV, superior mesenteric vein, and the splenic vein. Very important. Portal vein is formed by the superior mesenteric vein and the splenic vein. The right and left renal veins are going to drain blood from the kidneys directly into the IVC. A normal portal vein measurement is 0.7 to 1.5 centimeters. Here's a beautiful image of the portal vein. So it's pretty easy to find. It's in the liver. It's a pretty decent size. It's going to be red, and it's going to have a continuous Doppler flow that is going to be above baseline. Your hepatic veins, we term these as the Playboy bunny here. Can you see that? You've got the face, and then that's the IVC, the face, and then on the left you have the right hepatic vein, in the middle is middle hepatic vein, and the left is left hepatic vein. Okay? All right, renal transplant, allograft. Let's talk about this, and then we're finished. So both living related donor and cadaveric kidneys are implanted, most commonly in the right iliac fossa. Please note that when a patient gets a renal transplant, they don't take out the dead kidney. it stays in the patient. It will pretty much shrivel up and become very small, and it will be very hard to see, but that kidney is not taken out. They put a new kidney into usually the right iliac fossa, which is like the pelvic area. It's a very superficial, very close to the skin, very easy to image. And again, I think the only place we're going to see this will be UK. Post-op exam, the transplanted renal artery vessels are anastomosed either end to side with external iliac artery or end to end with the internal iliac artery. Venous anastomosis connects the renal vein to the external iliac vein and end to side fashion. Most often, the donor ureter is implanted into the bladder directly. You're going to use the 5 to 7 megahertz probe, the phased array again. Longitudinal and transverse approaches are utilized. You're going to get a length and AP. Length is what we'll get in a longitudinal view of the kidney. AP is the measurement we'll get in the transverse diameter of the kidney. B mode observation to look at the parenchyma and echogenicity. B mode again, we're going to look for any fluid collection, cysts, tumors. Doppler spectral analysis of the aorta, internal or external iliac artery, donor renal artery, external iliac vein, donor renal vein, and allograft vessels. Peak systolic and end diastolic velocities are obtained and flow quantities assessed as to whether the flow resistance is normal or abnormal. Again, let's see. B mode signs of rejection are going to be increased renal transplant site, increased cortical echogenicity, hypoechoic regions in the parenchyma. Doppler analysis continues to be a source of discussion. Renal vein thrombosis and infection can actually increase pulsatility in the renal artery, so they don't love to use that as criteria. Biopsy is going to be the most reliable method for rejection diagnosis. Let me know if you have any questions. This was a very big PowerPoint. It's a lot of material. It's a lot of information for you all to memorize. Again, please, it's only 2 chapters. So please, please, please read these chapters over and over again and listen to and review these PowerPoints over and over again.